Okay, so when you're trying to figure the extent of burns, I really recommend that you look at your book because this particular picture doesn't show the whole thing. The head and neck is worth 9% of when you're talking about the percent body burn. The posterior trunk is worth 18%, and the anterior trunk is worth 18%. Each upper extremity is worth 9%. External genitalia is worth 1%. Lower extremities are worth 18%. This particular picture shows, the hand's worth 1%. So, anyway, so if somebody was burnt over, both legs, from the waist down, we would estimate it to be probably like a 36 to 40% body burn. That would give you an example of how to do that. Okay, for children, we use a little bit different of a classification because they have a much larger head and different body proportions than adults. So, again, the Lund-Browder classification is what is commonly used for children as opposed to just your typical total body surface area body burn. As far as the pathophysiology of burns, we talk about the integumentary system and the damage done there by zones. We call them zones of injury, and there's 3 different zones. The zone of coagulation is the central part of the burn, and that's irreparable damage that's done. The zone of stasis surrounds that necrotic, irreparable damaged area, and that's the area of cell injury and compromised tissue perfusion. And then the zone of hyperemia is where the least thermal damage has occurred and there's minimal cell injury. So as a PT, we have to be very careful to protect that zone of stasis in the burned individual. We don't want to re-traumatize the tissue. So we have to be careful with movement and exercise and dressing and any sort of assistive devices that we prescribe or use, or splinting, all of that kind of stuff. You want to protect that zone of stasis. You don't want to irritate it so that it won't heal. The cardiovascular system, there's something called burn shock. And when skin cells die, they release lots of enzymes that cause the capillaries to become more permeable, and so you lose lots and lots of fluid. I've already talked about this, and you get lots and lots of edema. If your skin is intact, even though it's dead, you haven't burnt it off, the edema is going to, progress, and you could have eschar and then require an eschorotomy. You can leak a lot of fluid, and so their cardiac output is decreased drastically because of the volume of fluid that they lose. You also get this vasoconstriction occurring because as the cells die, they release bradykinin. So all of these things result in decreased circulating blood volume and the potential for microemboli formation. And then you also can have tissue necrosis, organ dysfunction, and even death because you get oxygen deprivation. So as PTs, we have to worry about people who are tachycardic and who have low blood pressure. We have to monitor them carefully. We have to worry about edema, and we have to make sure that we don't limit venous return or cause any sort of arterial occlusion. We have to be careful. Burns can cause this tourniquet-like effect, so we have to palpate pulses or do Dopplers if necessary, and we have to watch out for compartment syndrome symptoms. So these are all your responsibility with the burn patient, to pay attention to what other signs and symptoms other than pain or discomfort that the patient might be having. With the pulmonary system, they're going to have pulmonary edema and acute respiratory distress syndrome. They're more prone to have pneumonia, and pneumonia and inflammation of the lungs is the major cause of morbidity in burn victims. Inhalation injuries are responsible for 20% of burn mortalities. So if somebody's in the fire where they're breathing in hot air, they may not have been burned so badly exteriorly, but if their lungs were burnt badly, that can still cause mortality. They need to eat a lot, even though they don't feel like it. They need a very high calorie, very, very high calorie, so upwards sometimes of 5,000, 6,000, 7,000 calories a day. High protein diet. We've already talked about how important protein is in wound care and wound healing. Their basal metabolic rate will double or triple with a burn injury. and their core body temperature and skin temperature are elevated. So they have an increased resting oxygen consumption compared to people who don't have burns, and they have what we call sustained hyperglycemia, increased fat catabolism, and decrease in body mass. So they are burning themselves up alive, literally, metabolically. And you have to get them to eat. And that is one of the most difficult things to do in a burn unit. These people hurt, they don't feel good, they're exhausted mentally and physically. And the last thing they want to do is eat. And so there's all kinds of ways to try, as many high protein, high calorie shakes you could. We didn't care in the burn unit we were in. We didn't care what they ate as long as they ate. Now we know more now. They do need to have a high protein diet, but that might not be palatable to them. So really at first, just calories, as many calories and fluid as you can get into them as they can tolerate. But you do generally expect a decrease in body mass because they usually just can't eat enough to keep up with what they need to do to heal. Sepsis and infection are very common in burn victims. People that die from burns, most of them do die because of an infection. You have bacteria everywhere. And what you have on your skin that you normally are protected from before your burn may be what causes you to become septic. And your inflammatory response isn't as effective in cleaning up the wound in burns as it is in just in other types of wounds. So there's a lot of things that impair your immune system. And last but not least, the psychological stress of a burn is huge, especially if it's a disfiguring burn. People have to deal with friends and family not recognizing them sometimes. They don't look in the mirror, they don't recognize themselves. It can be a very difficult time for them. And we know that if your psychological system has had an assault, there's a grieving process that they go through, that's going to impair their immune system too. So it's in a severe body burn that has disfiguring components to it, these people are grieving. The person they knew is that we're used to seeing in the mirror isn't there anymore. And it's very, very difficult for them. So what happens when somebody comes in for a burn, a bad burn? The medical team will meet, and the very, very first thing they're going to do is establish and maintain an airway. So is the burn bad enough that the patient may succumb to swelling and we may have to intubate? So they'll try to make that determination as quickly as possible. Then the second thing they do is to try to prevent cyanosis, shock, and bleeding. So they'll start IV lines, IV fluids right away if they can find veins to start them in. And then they'll establish a baseline data, which means, what's the extent of body burn, what kind of a burn is it, all their vitals, any vital you can imagine, they'll be recording and monitoring very closely. Preventing and reducing fluid loss, again, by starting them on IV fluids, doing what they can to stop any bleeding. Then they start to clean the patient in the wound. So once they've kind of got them more stable medically, then you'll start to take care of the actual burns themselves and any other injuries that they might have sustained. If they broke their leg, we don't really care right away. We're going to try to make sure they're not going to go in, have a heart attack because of their burn, something like that, or not be able to breathe. So at that point in time, any other injury that they might have sustained, as long as it wasn't life-threatening, will be assessed. Certainly cardiopulmonary complications, they're watching them closely because they do have cardiac dysfunction. They'll go into arrhythmias real easy. They're completely stressed, and their cardiopulmonary system definitely shows that stress. And then you'll start to do debridement if it's called for. Generally at that point in time, they try to get the patient some sort of medication to control their pain and make them more comfortable. We've already talked about sharpened surgical debridement, so we won't talk about that again. We've talked a little bit about topical medications. After you do debride, these people do need the antibiotics. Absolutely need the antibiotics. This is not your typical chronic wound where I said, no antibiotics, try to hold off on those. These folks need them because they are so susceptible to infection. They come in, there is no not infected burn. Let's just put it that way. I mean, all burns are infected because they're just almost can't not be. So a topical medication is applied once or twice daily, and then they are always covered with dressings. The most common one is sulfadiazine or sulfadine, is what you might have heard. That's effective against Pseudomonas. Sulfadiazine, is effective against Pseudomonas. Silver nitrate is a very useful, and it actually is silver. That's what it is. Silver nitrate is very useful for surface bacteria. It will stain the wound black, so you have to know what you're using and know what to expect. But you might use that. Bacitracin is effective against gram-positive organisms. Bacitracin is effective against gram-positive organisms. And then another one that you'll run into is Travase or Elase, and that's an enzymatic debriding agent. It's not antibacterial, but it is good at going in and cleaning up the wound if there's any debris early on in the burn. Here are some pictures. This one you almost can't tell what it is. It's a type of a whirlpool. This is a hover tank. We don't use these hardly anymore. This is more what you're going to see. This was taken off a kids page for burn care, the pediatric burn unit, and to show that Elmo, I don't know if he looks happy or not, but Elmo is sitting on the spray table, and it'll be covered with plastic if that's the setup that you use. Sometimes they're stainless steel, but then what you're going to use is gentle water to irrigate the wound most of the time. Okay. Surgical management. So some people have full thickness burns that require grafting, and there are 3 different kinds of grafts. There's something called an autograft, which is a skin graft that uses the patient's own skin. Okay, they'll have the skin graft done, and I'll show you the donor sites in a minute. And the graft will be put on the burned area, and then you leave them alone. You leave the grafted area alone for 4 to 7 days. So let's say they burnt their hand and they have a skin graft from their thigh or their buttock or their trunk, and they graft the hand. We would not do physical therapy to the hand generally for 4 to 7 days because it takes that long for that little graft to establish. And I'll show you pictures of the grafts in just a minute. An allograft is a cadaver skin, and I'll talk a little bit more about that in a minute. And then a xenograft, or another word for that is a heterograft, is usually pig skin. And pig skin we tolerate it well. It's generally used it is a temporary covering. And the reason that you would use either cadaver skin or pig skin as a temporary covering is because it does protect the burn. It keeps it warm. It insulates it. It will allow some normal physiologic processes to go on underneath the burned skin, even though it might still need a skin graft. And it might allow the patient to be able to grow more graft sites. And some people don't have a lot of places that you can graft from, or maybe they need to give the patient a break for a little bit from grafting, and they're grafting a little bit at a time, so they may use this temporary covering. The body will reject. They don't even suture on pigskin, I don't think. They just pretty much bandage it in. They may suture on the allograft, but the body will reject that in a matter of weeks. Generally, it will finally realize this is a foreign object, and it will mount an immune rejection reaction against it. So, an allograft, again, is cadaver skin. It's kept in frozen skin banks. I've given you a link to an organization called the Musculoskeletal Transplant Foundation, and it is near and dear to my heart because my daughter was a donor. And so it's a little hard for me to talk about this, but I copied this from a Facebook post that I put up a year ago when I got a letter back from the Musculoskeletal Transplant Foundation about Maggie's donation. And since Maggie was in a car accident and she did suffer cardiac arrest, they couldn't use her vital organs like her heart and her kidneys or her liver, because that requires that the patient be brain dead, but their heart still needs to be beating until they go and harvest the organs. But what they can do with people like my daughter is that they can use tissue grafts. And I just wanted to impress upon you guys how important this is for people to be donors. But then I think how important it is for us as healthcare professionals to understand what it means for someone to receive a graft, a donor graft. We talk a lot about in orthopedics. Oh, they had an allograft. They had an allografted Achilles tendon. They had an allografted patellar tendon. And we just kind of toss those terms around with kind of a cavalier attitude. And what I want you to remember is that there's a family behind every single one of those donations who are heartbroken. And I think we forget, and we treat these things like they're disposable. And you just need to understand that somebody's baby, maybe some mother, maybe some father, maybe some grandmother, maybe some daughter or son, lost their loved one, and it's just something I think we need to acknowledge. I was lucky in that I found out what happened with Maggie's donations, and for all I know, she is still donating. But I'll just read this to you. She helped 9 people. She helped 2 people with eyesight because she donated her eyes. But she helped 9 people ranging in age from 18 to 76 years. The surgeries included 2 ACL repairs, 1 ORIF, 1 total hip revision, 1 medial patellofemoral ligament reconstruction, and several spinal fusion surgeries. She helped people from Wisconsin, Georgia, Pennsylvania, New York, and Arizona. So, and as far as I know, she was a skin graft. She donated skin too, because she donated everything. I allowed them to take anything and everything that they needed from her. So they took the long bones in her arms and her legs. They took her pelvis. They took her sternum. They took her heart valves. And they took her eyes. So I just think we need to be grateful that people are willing to do this, and just understand what being a donor really does mean. All right, I'm going to stop this for a minute and start up again.